I think we can start, Doctor.
Okay.
Thank you.
Good morning, everybody. So today we'll be discussing about management update of Crohn's disease, special emphasis on diagnostic challenge and monitoring. Can you hear me?
Yes, Doctor, we can hear you.
All right. So this is the outline of my presentation. I will discuss about introductory part, general concepts about inflammatory bowel disease, especially Crohn's disease. And we'll see what are the challenges we usually face when we manage patients with Crohn's. And then again, we'll discuss about setting treatment targets, selection of therapy, the current development, and also finally we'll see monitoring of response. So to begin with, inflammatory bowel disease is it's a non-infectious chronic inflammation affecting the entire gastrointestinal tract. Especially Crohn's disease has special predilection to the ileum and the proximal part of the colon. The major pathophysiologic event is not well understood, but there are some theories. One of the most important theory is dysregulated or uncontrolled immune response triggered by some factors, some environmental factors, in a genetically prone individuals, those with CAR15 mutation, is considered to be a major pathophysiologic event that leads to a chronic persistent inflammation of the bowel. IBD, especially Crohn's disease, is a lifelong illness with significant morbidity and mortality. Study shows that it is responsible for hospitalization, especially during the first year of diagnosis. In about 1/3 of patients could get hospitalized due to different reasons, mainly surgery-related reasons. And in 5 years' time, more than half of patients with IBD could present with end up in hospitalization due to different reasons. And also it's responsible for increasing all-cause mortality and certain cardiovascular events also noted to increase in patients with Crohn's disease. And it's also responsible for a low health-related quality of life. It's not a GI disorder only, it can cause some mental disorder, rate of depression is high. This contributes to a poor quality of life in patients with inflammatory bowel disease. It is considered to be a disease of high-income countries, developed world. But if you see the trend, the incidence is declining in the high-income countries, but still they do have a high number of cases, and it is still a major public health issue. Whereas in recently we have noted a shift in epidemiologic pattern. Newly emerging countries, they have noted an increase in rate of inflammatory bowel disease. This is one reason, and the other is those developing nations, nations with limited resource, they do have a large number of population, and considering that, especially in Asia, the inflammatory bowel disease rate is increasing from time to time. And in Africa, well, we do not have much data, but study in West Africa and in South Africa showed that IBD is becoming more common in some settings. And the problem in African countries is because of this different limitations, which I'm going to discuss later on. Usually IBD is diagnosed late, and patients may present with complications as a result. So that's a major problem. We do have several reports from the West African countries on the usually institutional-based studies. They have tried to show IBD is becoming more common even in Africa. So it is a progressive disease which can cause luminal damage. As you may know, Crohn's disease it's a transmural process, and as a result, patients may present with complications as time goes by. Usually, there are some flares, and most of the flares are silent and followed by periods of quiescence. And these are responsible, and most patients may not show symptoms. And these periods of quiescence with intermittent silent flares are responsible for ongoing luminal damage and complications. And in about 1/3 of patients, they may present with strictures, fistulas, or abscesses as a result. And if you see a long-term complication, nearly half of patients may require surgery within 10 years of diagnosis. And the problem with surgery is once they do surgery, the risk of recurrence is high. The clinical relapse rate, for instance, is about 53% in 1 year after surgery. And if you compare that with endoscopic recurrence is much higher than the clinical recurrence rate. But still, it's a major problem. They require surgery, and following surgery, they develop also several bouts of relapse and recurrence. So this slide shows what happens if you miss diagnosis, if you fail to give treatment early. What will happen is, there will be an ongoing damage, and this leads to different complications, as it is depicted in the slide. Where if you have the chance to make an early diagnosis, and if proper treatment is given, and if you can make sure that tight control is achieved, you can reverse or you can prevent most of the complications. So early diagnosis means a lot in patients with Crohn's disease. So what's happening in our situation, whereas you have seen the previous morbidity reports and the like, inflammatory bowel disease is ranked as third major outpatient reason for outpatient visit, following chronic liver disease and GI malignancies. So it's not something that we should undermine, especially in the outpatient setting. It's one of the most common reasons for visit. And a study was conducted by one of our graduates last year, and he has evaluated 122 IBD cases, and amongst 73 of them were patients with Crohn's disease. And he has tried to demonstrate that IBD, especially Crohn's disease, is disease of the young. Mean age at diagnosis in our setting is 26.4. And the most common disease behavior which was documented was the inflammatory variant, as it was the case in other parts of the world. And the most common phenotype, disease location being the ileocolonic areas. So it's similar with other parts of the world as well. Surprisingly, about 1/3 of our patients have received anti-TB treatment before the diagnosis of IBD or Crohn's disease. So you can see how significant the challenge is. Nearly 1/3 of them had received anti-TB. And among those 73 cases, 20.5% diagnosed to have Crohn's disease after having surgery for different reasons, without prior treatment. Most of our patients are had received corticosteroid for initiation of treatment. Any kind of response was noted in more than 90%. But the problem in our patients are most presents with frequent relapses. And in about 10% of them, they continue to have symptoms. And the other major issue here is the rate of surgery. Among the 73 patients, 41% had surgery previously. Surprisingly, only 22% of those who had surgery was continued with some form of therapeutic options, some of them on immunomodulators and some on antibiotics like metronidazole. That's surprisingly, again, the recurrence risk was very low, 4.1%. If you see my previous slide, post-surgical recurrence, clinical relapse is really high. 1 year clinical relapse was as high as 53%, but in our situation, despite the paradox is most of our patients were not receiving any kind of treatment, but despite that, the risk of clinical relapse was really low. So this is the data from which was conducted between January to August 2020.
Dr. Rezene,
Yes.
what was the combination 9.6% received? The combination.
Well, most of the time, corticosteroid and azathioprine are the combinations which was given. That's what we usually do. Because, I'm going to discuss it later on. Azathioprine usually takes longer to act. It's not good for induction of remission, but it is a drug which is good for maintaining remission. So we combine steroid with azathioprine as a combination of treatment.
And the median duration of follow-up in your cohort?
Well, this is a kind of cross-section. I didn't find a kind of median duration of treatment or follow-up, sorry. So shall I proceed? All right. So diagnosing Crohn's disease, it's not an easy task because it needs a combination of clinical, radiological, especially cross-sectional imaging, and in most of the cases, it requires endoscopic evaluation with histopathology. And some groups of individuals, serology can also be used, especially in differentiating between ileocecal pathologies like Crohn's disease and tuberculosis. But combination usually it helps to reach to a final conclusion. So if you have the chance to do ileocolonoscopy, and this is what usually not, you'll see some kind of punctate-like ulcers, looks like an aphthous ulcer. And some patients may present with longitudinal deep ulcers with stricture. And most of the cases, the ileocecal valve will be affected, especially in patients with Crohn's disease, unlike in patients with tuberculosis of the ileal region. And histopathologically, the hallmark is non-caseating granulomatous lesion. The granuloma usually is a small one, but only few groups of few individuals have this kind of abnormality on histopathologic study. That makes it challenging again to differentiate from mimicrers like intestinal tuberculosis. So the caseating granuloma usually is usually it's located distant to the area of architectural distortion and fibrosis. In some group of individuals, you can also identify crypt abscess. So this is how we make a diagnosis of ileocecal Crohn's disease. It's reachable. And problem is with small bowel and upper GI Crohn's disease where endoscopy cannot be reached, and taking biopsy specimen will be very difficult. In such kind of situations, certain there are available diagnostic modalities like capsule endoscopy. And again, enteroscopy can be attempted to diagnose proximal and mid-GI Crohn's disease. So what are the challenges that we usually face in diagnosing Crohn's disease? The most important challenge is awareness from the patient side and awareness from the healthcare professionals. And the second one is scarcity of diagnostic service. It's demanding. It needs a combination of not only clinical, but it requires cross-sectional imaging. It requires endoscopy and good histopathology service. So lack of these diagnostic services, and most of our patients may not be able to pay. These are most important challenges that we usually face. And another important one is infectious mimics of inflammatory bowel disease. This holds true in resource-limited settings, especially differentiating Crohn's disease from intestinal tuberculosis, differentiating proximal and distal colonic Crohn's disease from certain infectious causes like amoebic colitis could also mimic inflammatory bowel disease. Recently, I have seen a patient who was referred to me for colonoscopic procedure. His major presenting symptom was bloody diarrhea. And I did colonoscopy, and I have noted this classical cobblestoning appearance primarily affecting the proximal colon with some white-headed nodules. It looks like a micro abscess, but it was a nodule. And I took biopsy, and the biopsy result turned out to be leishmaniasis of the proximal colon. So some infectious causes could mimic inflammatory bowel disease. And the other one is limited access to therapeutic options. Nowadays, the mainstay of therapy for unresponsive, mild, and severe disease or high-risk disease is biologics, but biologics are not readily available and they are very much expensive. And the other one is high risk of opportunistic infections with immunomodulatory therapies. The prevalence of viral hepatitis is high, and so does the prevalence of latent tuberculosis, and there is a risk of reactivation. So what should we do when we come across a patient who is having, who is suspected to have Crohn's, and we have to exclude as well intestinal TB? A couple of weeks ago, we had a patient at B5 who was diagnosed to have tuberculosis, but colonoscopy report revealed some strictures, and we had a challenge to differentiate Crohn's from tuberculosis of the bowel. This holds true in most of our cases. And don't forget that 30% of our patients at the GI unit had received anti-TB treatment before they were diagnosed to have Crohn's disease. So what are at least some parameters that would help us to differentiate Crohn's from intestinal TB? Symptom-wise, it's really hard to differentiate, but usually patients with tuberculosis, they tend to have relatively shorter duration of symptoms with some systemic symptom like fever, weight loss, and the like. And the risk of obstruction and abdominal pain would be higher in patients with intestinal TB than patients with Crohn's disease. When you have the chance to do a ileocolonoscopic evaluation, there are some signs that might suggest Crohn's disease. Those are especially the nature of the ulcer, the location, involvement of the ileocecal valve are important parameters that could help you to differentiate. Again, this is not a hard and fast rule. It doesn't mean that you can confirm a diagnosis of Crohn's disease just by the morphologic appearance, but it can still have high index of suspicion, and you can evaluate it further by using histopathology. So patients with Crohn's do have long segment and multiple segment involvement, and they tend to have ileocecal valve damage with stenosis, and proximal distal colonic involvement is much more common in Crohn's disease and than in patients with tuberculosis. The patient I told you earlier was found to have rectosigmoid, I think a distal colonic stricture based on the previous reports. So the chance of having Crohn's would be very much high. She needs re-evaluation again after this trial of anti-TB treatment. And the other important parameter that we should use is the radiology, cross-sectional imaging. Radiology can give us lots of information in differentiating Crohn's versus intestinal TB. One of the most important criteria is the presence of fibrofatty proliferation with mesenteric inflammation. We call it a Combs sign. This is usually a sign of Crohn's disease, which is not commonly seen in patients with intestinal TB. Presence of abscess, fistula, and when there is a stricture tends to be long, and it is eccentric in nature. And also there is, if you have the chance to assess the visceral fat and subcutaneous fat, if the ratio exceeds 0.63, it could favor Crohn's disease and intestinal tuberculosis. On the other side, if you have the chance to get lymph nodes, big hypodense lymph node with high density ascites, concentric stricture, all these favors intestinal tuberculosis. So serology has a minimal role in diagnosing Crohn's disease, but it can help you to diagnose at least intestinal TB, like interferon gamma release assay, or if you have the chance to do some immunohistochemistry studies from the granulomas, or if you can run gene expert from the sample, this can help you to diagnose intestinal tuberculosis. So what happens when you fail to diagnose Crohn's disease and continue to give empiric anti-TB treatment? This is a study which they have tried to compare those who received anti-TB treatment and those who have never received anti-TB treatment but was diagnosed with Crohn's disease as in the early and received proper treatment. So they have tried to see the rates of complications like stenosis, fistula, and surgery. So what they have identified is the cumulative probability of stenosis was found to be significantly higher in those who received anti-TB treatment prior to the diagnosis of Crohn's disease. A major reason for this is diagnostic delay. The median time of diagnostic delay is about 18 months. So if you fail to diagnose Crohn's and proceed with anti-TB treatment, complication rate could be higher. So this is the recommendation in case of difficulties. What should we do? Where we should give priority to, obviously, to anti-TB treatment, but patients should be followed very closely. We shouldn't delay unnecessarily for a long period of time to diagnose Crohn's disease. So 2 to 3 months later, we need to follow them clinically and preferably with colonoscopy. So if you can detect ulcers, strongly suggests Crohn's than tuberculosis. If they respond, then colonoscopy can be repeated at 6 months to confirm that we are dealing with tuberculosis of the small bowel than Crohn's disease. But if patients to have a persistent ulcer, and the other possibility than Crohn's disease is MDR tuberculosis. A study which was conducted in Taiwan showed that 13% of patients who had intestinal TB had MDR TB. So if they fail to respond to the initial anti-TB trial, the possibility could be Crohn's disease, but it can still be multi-drug resistant tuberculosis. So what about hepatitis B virus and inflammatory bowel disease? Well, all patients with IBD, Crohn's disease, should be screened for inflammatory, for hepatitis B virus. And the reason is obvious. Most patients will end up either with immunomodulators or with biologics. Then these are potent immunosuppressants which can lead to hepatitis B virus flares. So in order to prevent that, all patients should be screened by using surface antigen markers and core antibodies. If they are negative, then they should be vaccinated considering their risks. And if they are positive, treatment should be given. Effective treatment should be given 2 weeks prior to the initiation of treatment. And that treatment should continue 12 months after adequate immunosuppression has been achieved. The other problem is when they develop hepatitis B virus flares while they are on immunosuppressants. And what we should do is immunomodulators or biologics should be withheld for some time. And we have to monitor the level of viremia frequently. And once the level of viremia starts to decline below 2000, then immunomodulators or biologics can be reintroduced. And patients should continue to take the preferred drugs for hepatitis B virus treatment. So what are the treatment targets? Previously, symptomatic resolution was giving due attention, but we know that there are several limitations for symptomatic resolution. Patients, as I have tried to mention earlier, there are periods of quiescence and also some silent flares. Patients can still develop complications despite symptomatic resolution. So in order to prevent progression of disease, we need to aim for mucosal healing than symptomatic resolution. So if we can achieve mucosal healing, then there will be threefold likelihood of achieving long-term clinical remission, and there will be a twofold decrease in the risk of relapse after treatment discontinuation. So we can prevent relapse and it can prevent also long-term remission. You can achieve long-term clinical remission by achieving mucosal healing. So this slide shows the effect of mucosal healing in predicting long-term outcome. You can easily see the difference of those who has no mucosal outcome. The risk of having major surgery would be higher. But those who have achieved the complete mucosal healing or even partial mucosal healing, chance of having major surgery would be minimal. So now there is what is called the treat to target concept. This treat to target concept would help us to achieve our major goal, which is mucosal healing. So in this treat to target treat to target approach, what we need to do is we have to use different combinations, not only clinical evaluation, but there are several markers, cross-sectional images, and different, including colonoscopy that we should use to make sure that mucosal healing has been achieved. And this follow-up should continue until we make sure that our target is well achieved. So, and again, we have to set a definitive time for follow-up. Once we confirm the diagnosis of active Crohn's disease, within 3 to 4 months, we have to follow response by using different markers. And within a 1 year period of time, at least endoscopic evaluation has to be repeated to document or to make sure that this mucosal healing has been achieved. So what are the guiding principles in treating Crohn's disease? Previously, we used to give due emphasis to disease activity, this Crohn's disease activity index, the Harvard show index, and also now currently we are using the patient reported outcomes to assess disease activity. But disease activity gives you a kind of snapshot. It doesn't tell you the whole disease course. So now the guiding principle is to use a combination of disease activity, severity, and risk assessment as well. Those with limited disease activity could have a high risk of progression who requires an intensive treatment. Again, the second principle that should follow is we must have a scheduled comprehensive monitoring to assess treatment response. We are going to deal about it later on. And the third one is changing therapy as early as possible. We shouldn't just continue immunomodulators. When immunomodulators are, when they have failed to achieve remission, then we have to proceed to the next step as early as possible in order to prevent complications. So this is what we mean by the role of disease activity, severity, and disease risk. Activity usually is a snapshot. It tells you only what happens at that specific period of time. Based on this disease activity, can classify these as mild, moderate, or severe. But it doesn't prevent complications if you focus only on the disease activity. Whereas disease severity, the variables are very broad. In addition to symptoms and objective findings, you can include treatment experience, previous surgery, biomarkers, functional aspects can be included in this disease severity. Whereas in this disease risk, it predicts long-term outcomes. Again, factors that complicate the course can be included in this risk assessment. So these are factors which predict high, moderate to high risk disease progression. Well, you may not find that in the disease activity, for instance, and may not find it in the disease severity. Here, I can assess the age of patient, extent of the disease, location, behavior, the nature of the ulcer itself, whether the patient had previous surgeries, treatment experience like early use of corticosteroids, and certain lab parameters can be used to stratify patients' risk groups. So based on this assessment, you can classify it as low-risk patients versus moderate or high risk. Those who are diagnosed to have low-risk ileocecal Crohn's disease can receive steroid. That is the mainstay of therapy. Those with colonic-only Crohn's disease, prednisolone is a preferred therapeutic option that can be given from 2 to 4 weeks. After 4 weeks of therapy, maybe discontinuation or changing to a maintenance therapy is recommended. This is for with low risk patients, but those with moderate to high risk based on the risk assessment, disease activity and severity. Ideally, these are kind of patients who should be given biologics. Biologics are preferred in such groups of individuals. So this is a disease algorithm. As I tried to mention, mild to moderate disease, the mainstay of therapy is steroid. 5-ASA has a very limited role in patients with colonic only Crohn's disease. It's not indicated in idiopathic types of Crohn's disease. Even in colonic Crohn's disease, evidence are not such strong to recommend routine use of 5-ASAs in treating colonic Crohn's disease. So the mainstay of therapy for mild to moderate Crohn's disease is steroid. You can use budesonide. If not, prednisolone can be used instead. For those who are having mild to moderate but with high risk to progression, again, they can be tried with immune modulators, with steroid and other immunomodulators. But in this kind of individuals, they will be benefited from these biologic therapies, preferably in combination with some immunomodulators like thiopurine. Response, how should we monitor? Well, there are certain terminologies that we usually use. We frequently use a complete remission, meaning patients should achieve symptomatic and endoscopic remission, or they should also achieve symptomatic and radiographic instead of, if you cannot do endoscopic evaluation, you can use radiographic remission instead. So if you can combine these two, and if patients are achieving those two targets, you can say they have achieved complete remission. For one of important, this monitoring part is clinical monitoring, but clinical monitoring alone is not suffice to address the issues. It may not be accurate to measure inflammation, and it predicts less, the prediction of complication would be less if you stick to clinical monitoring alone. It poorly correlates with endoscopic recurrence, especially in post-surgery patient. And the other important thing is some clinical symptoms could occur due to different reasons other than activity of Crohn's disease. Here, the best example is patients with Crohn's disease can have bile acid diarrhea. They can have small ileal pathologies, and this ileal pathology could contribute to bile acid diarrhea. Patients can develop stricture, and patients with stricture can develop symptoms like abdominal pain. They can still develop bacterial overgrowth syndromes that could mimic disease activity. In actual sense, patients may be suffering from something else. And another important issue is the issue of superimposed irritable bowel syndrome, which occurs in patients with Crohn's disease, can give us a false impression of disease activity. So these are the challenges with clinical monitoring. You can use CDAI. Crohn's disease activity index usually is reserved for research purposes. It's cumbersome, and it's not easy to practice on day-to-day clinical, to apply it in our day-to-day clinical practice. And the other one is a modified type, the HBI. Again, it's easy to use, but again, it's not, the correlation is not perfect with CDAI. And the third one is the modified type of patient-reported outcomes. You can use diarrhea and abdominal pain, or you can add general well-being. Study was conducted to see whether these two PRO and CDAI are correlated well. So PRO2 of less than 8 can be well correlated with CDAI of less than 150. This can be used as an entry point, but alone it will not be enough to assess ongoing mucosal inflammation. And the other important issue is the issue of biomarker. Here, C-reactive protein is very important. The correlation with endoscopic activity is very good. Usually it rises 4 to 6 months prior to the clinical relapse, as it can be used to prevent relapse. You do CRP, and if CRP starts to raise, you shouldn't wait until patient starts to have clinical activity. And the other important part is following biologic treatment, it can easily be normalized to baseline. So that can be, if you achieve a normal CRP within a short period of time, then that would be a sign of sustained, achieving sustained long-term response. It is highly specific, but sensitivity is low. In that case, it can be used to follow for short to medium-term targets, but it's not sufficient for the long-term targets. So this slide shows the role of CRP in infliximab-treated Crohn's disease patients. So sustained response means long remission. But if you fail to achieve normalization of C-reactive protein, patients continue to have symptoms, ongoing inflammation, and complications will occur. And the other important biomarker is fecal calprotectin. This is an inflammatory protein which resides in the cytosol of neutrophils. It is a marker of intestinal inflammation. The correlation with the clinical parameters of activity and endoscopic parameters is very good. A study was conducted to see whether fecal calprotectin is well correlated with simple endoscopic scoring in Crohn's disease. And they have, it's well documented that fecal calprotectin is well correlated with endoscopic activity. So in an area where doing endoscopy is not a possibility, then fecal calprotectin can replace as a marker of ongoing inflammation. So it helps to identify high risk of relapse. It is more consistent again in detecting recurrence than CRP, especially in post-surgical patients. So this slide shows fecal calprotectin predicting endoscopically active disease and comparing with Crohn's disease index or endoscopy index of severity. So it is well correlated, and the sensitivity, as you can see, is 91%, and specificity is a bit low. Positive predictive value is about 76%. If you compare that with the CRP of greater than 5 milligram per liter as a marker of inflammation, here the sensitivity is low, but it's much more specific. So, short-term relapse after stopping infliximab treatment, again, fecal calprotectin can predict short-term relapse after stopping biologic agents. So it can proceed doing colonoscopy. You can do fecal calprotectin first, and if you found it elevated, then you can proceed with colonoscopy to document relapse. So there is what's called STRIDE that helps to address this issue of treat to target in Crohn's disease patients. So based on this STRIDE recommendation, fecal calprotectin can be measured at week 12 following biologic treatment with, again, anti-TNF. Then if the level is below 300, there will be 50% decrease associated with corticosteroid-free remission at 1 year. Then if the level is below 500, then it has a high predictive value. And the other important issue is the cross-sectional imaging. Imaging can be used to assess, again, treatment response. Here, cross-sectional imaging, it correlates well with clinical response. There are different options like the MRE, magnetic resonance interrography, or CT interrography can be used. Again, small bowel ultrasonography can also be used to assess treatment response. So, especially in one study, they have tried to see the role of ultrasound evaluation in diagnosing post-surgical recurrence. So, in this study, the sensitivity was 94%, and specificity was 84% in diagnosing post-surgical recurrence. Here, what you should do is you measure the bowel wall thickness, and if you follow the standard criteria, like more than 5.5 millimeter, it is strongly indicative of severe post-surgical recurrence if you compare that with the endoscopic criteria of recurrence. And the other part of follow-up is endoscopic monitoring. Here you can use the Crohn's disease endoscopic index of severity, or you can use the simple endoscopic severity. This is it can effectively detect relapse, so it can be used instead of this cumbersome index of severity instead. Rutger's usually is this is a score based on the colonoscopic evaluation. Usually it is helpful in assessing post-operative recurrence. This is a simple endoscopic scoring system in Crohn's disease. There are several parameters, and this slide shows post-surgical evaluation of recurrence using colonoscopy. Then you can use Rutger's I0, I1, and the like to assess degree of relapse. So intervals of monitoring, clinical monitoring can be done every 3 months, but endoscopy should be reserved to do it 6 to 9 months after initiation of therapy. Biomarkers can be evaluated 3 months after initiation of immunomodulators. What about adverse drug reaction? Most immunomodulators do have some degree of toxicity. The most common immunomodulator that we use here is azathioprine as part of maintenance treatment. Azathioprine can cause some degree of myelotoxicity. Here we do not have a chance to do TPMT mutation. Those who are having TPMT mutation are at risk of developing different side effects, including myelotoxicity. And also it is hepatotoxic, so liver, CBC and liver enzymes should be followed closely. There is some increment in the degree of non-melanoma skin cancer in relation to thiopurines due to different reasons. One possible explanation is the high rate of cutaneous HPV as a risk factor, and probably the other one is DNA damage, which can be done by the thiopurines, could contribute to an increase in risk of non-melanoma skin cancer. So that should be followed very closely. And in case of pregnancy related to thiopurine use, there is no, well, we know that immunomodulators like thiopurine, mercaptopurine are class D drugs, but considering the degree of frequent flares and the like, discontinuation now and then might not as such be recommended. But as you may know, IBD in general can cause growth retardation and can contribute to prematurity and the like. That could be the reason. Otherwise, those who are taking azathioprine, if they get pregnant, abortion and the like is not recommended, even if the drug is a class D drug. And the other one, important thing that we need to consider is the risk of cardiovascular events in patients with Crohn's disease. So some studies try to demonstrate an increased risk of cardiovascular events in patients with Crohn's disease. So patients should be followed, especially those who are seriously sick. They need to receive prophylaxis against VT. So again, latent TB should be followed, especially those who are getting biologic therapies. There is high risk of immunogenicity. In such groups of individuals, there is a possibility of reactive therapeutic drug monitoring. So accordingly, we can also measure the anti-drug antibody levels, and accordingly, patients can be managed based on therapeutic drug monitoring and drug levels of the antibodies. So in summary, IBD is becoming more common, even in resource-limited countries. Awareness is crucial, and we have to improve access to care. Assessing Crohn's disease should focus not only on activity, but also we have to take into consideration the disease severity and risk assessment. Therapeutic options should be, previously we used to follow this stepped-up care approach, but nowadays we have to hit it hard, and we have to use the best treatment options available. We need to set an achievable goal, and treat to target is now a preferred target to achieve mucosal healing in patients with Crohn's disease. And therapeutic response should be followed by a combination of different parameters, including clinical, radiological, biochemical, and if possible, endoscopy to make sure that the goal has been achieved and patients have achieved mucosal healing to prevent complications. I think this is all what I have. Thank you for your attention. And if you have questions, comments, you are welcome.
So thank you so much, Doctor. So while you are accepting questions and comments, I will proceed with the post-test. Any questions, comments?
Can I ask if there is no one?
Please proceed.
Dr. Rezene, it was a very nice presentation. So, is there any HLA association? Because this is a disease that's in southern part of Europe, more than the northern part of Europe, like, the Mediterranean areas. And the other thing is a TB issue. I'm really, it's not very clear because M tuberculosis to affect that segment of MTB is by and large a pulmonary disease. Is M bovis, so that I know that these patients end up being treated for TB, and even following anti-TNF alpha, where there could be reactivation of latent tuberculosis. It's very difficult to clinically distinguish one from the other. But the TB issue for me is overblown because our problem with Mycobacterium bovis and non-tuberculous mycobacteria compared to M tuberculosis is less. These are questions and comments. Thank you for the nice presentation.
All right. Thank you, Dr. Wanderson. Well, as it is well known, understanding the pathogenesis of Crohn's disease, inflammatory disease in general, I think we need to, a lot of things has to be done. So far, what we know is there are some genetic predilection for Crohn's disease, especially this NOD2 mutation, which plays a major role in innate immunity, or the new name for that is CARD15. That is a well-known, it's an established fact. CARD15 mutation is a genetic predisposition to develop Crohn's disease. But the HLA and the like, there is no any definitive evidence of HLA. I know that there are certain geographic predilection that genetic predisposition alone might not be suffice to develop Crohn's disease. So far, what we know is CARD15 mutation is responsible predisposition for Crohn's disease. On top of that, there must be some environmental triggers. And among those environmental triggers are especially the westernization of lifestyle and early life antibiotic exposure and the like are becoming most important triggers. And on top of that, when there is a dysregulated immune response, that ultimately leads to bowel damage. So just to answer your question, there is no any specific HLA predilection to develop Crohn's disease. And the issue of tuberculosis, right? Theoretically, it seems plausible what you have described, Mycobacterium bovis as a cause of intestinal TB. But still, there are several cases of intestinal TB, be it Pork bovis or due to the other Mycobacterium species. And that is causing a significant challenge, especially when it comes to a diagnosis of Crohn's disease. A study was, I think it's published in the Lancet. They have tried to see the challenge of Crohn's disease versus tuberculosis in Asian countries and in India. So they found it really a major public health concern. Intestinal TB prevalence is high. Latent TB reactivation with especially the biosimilar biologic agent is really high in that part of the world. I think the same thing holds true in our situation as well. Any other question or comment?
Dr. Rezene, may
Yes.
I comment? Okay, so thank you very much for a wonderful presentation and very pertinent pretest questions. So we are also following patients on anti-TB with presumed and confirmed Crohn's disease. So the diagnosis is quite difficult because IBD itself also causes pulmonary manifestations. So it causes airway inflammation. It causes less commonly serositis and parenchymal lesions, not to mention drug-induced pulmonary manifestations. So usually IBD diagnosis proceeds elsewhere, and for us, it is mixed. So what is very difficult is in extrapulmonary TB, we diagnose or we get evidences of pulmonary TB by imaging, and one of the imaging features we see is bronchiectasis, which is the commonest airway manifestation in IBD. So getting bronchiectasis here in this case is not exclusive of pulmonary TB and or IBD. So these are one of the caveats in managing IBD versus Crohn's disease as well. Thank you.
Thank you, Hannah, for the compliment.
So, Doctor, can you see the chat box? There is one comment from Dr. Brahanu.
Okay.
Regarding azathioprine in pregnancy.
Okay. Yeah. Well, as I have tried to mention, azathioprine, thiopurine analogs are they are grouped under class D when it comes to pregnancy. So whereas methotrexate, which is a different class, it belongs to the class X. So methotrexate is strictly contraindicated in pregnant mothers. But when it comes to thiopurine, especially when we do not have enough option to switch, so it can be considered. That the problem with pregnancy and inflammatory bowel disease is not only thiopurine analogs. But you know, the IBD by itself can cause some degree of prematurity and growth retardation. That is the challenge to me. But if you do not have much to consider, then thiopurines can be still considered as a therapeutic, continue as a therapeutic option, because you know we do have only limited options. Biologic agents are considered to be safe in pregnancy, that could be used as an alternative. But if you do not have such kind of option, I prefer continuing using these medications. So the other question is leishmaniasis and incidental overlap, or well, it is. I think this is a kind of case report to me, because you know colonic leishmaniasis is not as such common. It mimics Crohn's disease. What I have noted is, diffuse cobblestoning appearance, mainly involving the proximal part of the colon. Well, I would consider Crohn's disease based on its appearance, but biopsy was taken and mastigotes have been demonstrated. That's surprising to me. I mean, it's a kind of case report. So it's not.
Dr. Rezene, is this HIV infected patient?
It's not HIV infected. That's what makes me striking again. I mean, this is a patient without HIV infection.
Very
So,
unusual. Yeah. Please report it. Yeah.
Obviously, I'm waiting for the biopsy. The full histologic analysis result. So it's not a kind of coexistence, but this is a definitive colonic leishmaniasis. I think these are questions.
Thank you. So,
histologic remission as a target to treat. As I have mentioned, endoscopy is part of technique, I mean, the remission criteria that we follow, right? Clinical remission with endoscopic or clinical remission with radiology. When we talk about endoscopic, we are not talking about morphologic appearance, but some degree of histologic changes could appear. So for the time being, when we talk about remission, meaning completely normal appearing mucosa, nowadays people are using the advanced eye scan and the like, advanced endoscopic techniques to see if there are there are still ulcerations which might not be visualized by the conventional endoscopic technique that we usually use. But short of that, histology alone might not be nowadays a kind of plausible criteria to consider in the treat to target. But if you achieve morphologic remission, on top of that, if patients are in a complete clinical remission, you can define you have achieved complete remission, short of this histopathologic analysis.
Thank you, doctor. So Professor Abate and Professor Yuenarag, I think they have comments.
All right.
Yeah.
Okay.
Hello, Dr. Rezene.
Yes.
Hello.
Proceed, please, Professor Abate.
Yes. Thank you. Just a few words. I really appreciate the excellent, extensive presentation. Regarding the experience in our setup, it's becoming common now to see IBD patients, especially Crohn's disease among teenagers and young adults. And we also see some clustering among family members, probably suggesting genetic predisposition. And the common site, as you rightly said, is ileocecal, anatomical location, although we can see some colonic and also duodenal Crohn's disease cases. And but the problem is they come late usually because of the delay in diagnosis due to limited awareness, as well as access to endoscopy. And the colonoscopy usually is routinely done, and therefore patients are usually tried on anti-TB, and when they fail, they come with complications, both luminal and extra-luminal complications. Important, Dr. Hanan has said, it's not unusual to find a patient presenting for this external manifestation, and usually IBD is not considered. So it is just to emphasize these points, and the challenge, as you rightly said, diagnostic and also access and cost of medication require lifelong treatment. And we should not forget also to consider surgery.
Okay. Thank you, Professor. Professor Yuenarag?
Thank you, Dr. Rezene, for the update lecture and excellent presentation. I have very small and few questions. The first one is, I just want to hear figures about the prognosis of this disease. Prognosis of inflammatory bowel disease in terms of figure. The other one is there any extra intestinal manifestations in association with endocrine disease, because we see several patients. So if, do you have some comments on these points? Thank you.
All right, thank you, Professor. In terms of figures, where we can classify it as initial response and a late response. So initial response following immunomodulators, more than 60% of patients achieve remission. And in fact, in our study, the study was conducted in our unit, the initial remission, rate of initial remission was really high, more than 90%. And the problem is, following this initial remission, during a maintenance period, significant proportion of patients continue to have relapse. And also about 10% of patients, they were found to have continuity of this clinical manifestation, despite treatment, despite maintenance treatment. So outcome, in terms of outcome, so surgery is taken as an important indicator. So the rate of surgery in our situation is about 41% of our patients, Crohn's disease patients, had surgery, and surprisingly, the rate of relapse, post-surgical relapse, is low. It's about 4.1%, but in other parts of the world, 53% of patients develop clinical relapse 1 year after having surgery for Crohn's disease. So this is not something that needs to be studied because there is a disparity between 4.1 versus 53. And the other issue is extraintestinal. The most important extraintestinal manifestation with Crohn's disease, the joint and skin eye involvement, but didn't come across with detailed endocrine abnormalities. What we know so far is cardiovascular events and venous thromboembolism are really high compared to the general population in patients with Crohn's disease. This is what happens. Thank you.
Okay, so thank you, Dr. Rezene, and the participants. I think for the sake of time, we need to end it here. So I will share the answers for the questions with the participants. So I think we shall end it here.
Thank you so much.
Yeah, thank you, Dr. Rezene, and have a good day.